Over to my left is Saad, as you know. At the back is Sajda, who you've met a few times now. Sharia is hiding as usual. And we've got a new cohort of candidates on the course who you may see within the room. And there's a lady at the back waving in the white top, Janet.
Hi.
Hi, Steve.
Good morning.
Steve, I know that you're busy, and I know that you've had a bit of a hectic morning, but if you could just spend a little bit of time, I've given a bit of a brief about your role and who you are and what you do, and management of a busy gastroenterology service, in particular endoscopy service, and I was hoping that you'd be able to chat to the people and let them know how endoscopy, demand for it, and how it's being managed, etc. Just give us a little bit of an insight over here.
So we run a medium-sized endoscopy unit in a large district hospital in the UK, and we're currently doing around about 12,000 procedures a year, and we're expecting that to grow year on year. Currently in the UK, predictions are 10 to 15% is the government's prediction. There's some other data from some of the cancer research societies that suggest we're going to see a 40 to 50% growth over the next 5 years. So it is that's a substantial pace to keep up. The pressures from as you know, with a state-run healthcare system, and the government is pushing the agendas of driving up quality, but also driving down costs. So 3 times you're trying to promote and increase quality, dramatically increase activity volume, and drive down costs. This is quite a challenge.
We froze. Internet connection problem? Do I need to do anything, Sharia?
What he said is, I don't know if everybody understood it. What he said is, it's a medium-sized gastroenterology facility. They do about 12,000 procedures, and they expect a 10 to 15% increase every year over the next 5 years. So they will at least be doing about 18,000 procedures by the end of 5 years from now.
Give me a minute.
And what the pressures they have is that on one hand they've got increased demand, on the other hand they have to maintain quality. So increasing quantity but maintaining quality at a reasonable cost. So that is the challenge that the British medical system is facing at the moment. There are major issues with cost, so they're trying to cut down cost, maintaining quality, and that is the issue.
He's told me wait.
Is there a problem at his end?
No, it's this end.
What's the problem?
I know Sharia ran out the door. He says, "What? Give me a minute."
You want to check, but I mean, you're getting the signals when you are calling.
But down here, there's nothing. again. Sorry, Steve. We did get you most of what you were saying about the demand on year, and they talk about the national screening programme, saying that there'll be a potential 50% uplift in demand as well for endoscopy. So and then the connection
dropped. So what I was
dropped.
saying was the big challenge is to drive up volume and drive up quality at the same time. Well, cost and income is going down. And the key things there, firstly, are just really good leadership. So we need to maintain the team's enthusiasm and involve them in what's going on, and have effective management of the unit with the lead clinicians and nurses and the administrative and management team all working together and trying to drive things forward. The focus very much on quality now really means doing these kind of volumes of procedures that we actually need to employ someone to produce the data. So we now have a data clerk in our unit whose job is to produce the data about all our quality measures. In the past, we used to do that in an amateurish way. One of our colleagues would kind of produce some charts every so often, and we'd look at them. But now we need to be much more rigorous. So every quarter we sit down and we formally look at accurate data on everyone's performance indicators, both as individual endoscopists and for the unit, whether it's completion rates or bowel prep quality, adenoma detection rates, and so forth. And but the most important thing is to make the patient experience the number one outcome, and so something that it's got to be a very personal approach to patient care, and that is about the ethos of the team, so that if everyone's really understands that, signed up to that, and enjoys delivering that personal patient care and makes the effort, that's absolutely key to maintaining drug quality and building the patient experience. And then they're so rewarding for people then in doing their work, that they really feel that they're looking after those individual patients rather than just being a cog in a huge high volume machine.
Excellent. Steve, can you just let us know a little bit about how the endoscopy unit has to be used to more effectiveness in the future? So currently, in the past, many units would work Monday to Friday, potentially 2 lists each day. Could you just give us some insight on how that is potentially going to change in the future?
So we're going to drive up volume, drive down costs, and make our services more available and accessible for patients who can choose to be ill at inconvenient times, or find it difficult to take time off in the working day. So the plant, like if you know that the costs of having the room and having the stack and the scopes, they're the big investment. Whereas the staff are a different kind of investment, and by working more flexibly, you can deliver a lot more throughput from your rooms. So currently we're running evening lists most days of the week, and a weekend list Saturdays and Sundays, and that's really the most cost-effective way of growing the volume and provides a much better patient experience. So we'll have a morning list, an afternoon list, and an evening list 4 days a week, on Monday to Thursday. Saturday and Sunday, we're routinely running 2 lists a day. There's scope there for more evening lists, for starting the working day earlier and doing some of the inpatients earlier in the morning. So that there's still scope to grow, but in terms of a system that's, like everywhere now, very constrained for cost, it is the easiest way to grow the service.
Steve, can I ask you about how training has changed how we deliver endoscopy and the effect of that on a busy endoscopy unit?
So the training in the past used to be fairly haphazard. Trainees used to come along to lists. Trainees often were, once they'd reached a minimal level of competence, were left to do procedures unsupervised and learn on their own independently. And I think we value the training very much more now. We value we enjoy it. It's great to see people learning, developing the technical skills. It's great to have some ownership of the training that they're experiencing. And it's good for the whole team as well when we start to run training courses to participate. It gives them an extra interest in their work, and they can from the wider team, the nurses, the auxiliary staff, they can participate and start to learn and understand more, and it offers them all some variety in their work. It makes us analyse our performance and understand it in a much better way as well.
And Steve, before I throw for questions to the people on the floor, can I just ask? I believe, and I'm going to make a statement, and I'm going to ask you to comment. I believe that King's Mill is a very unique hospital, where we've got a lot of senior guys who are very keen on teaching and development, and that we work as a team. There isn't surgeons and there isn't gastroenterologists who work separately. We all seem to work together. We all seem to want to have the same goal. Could I just ask you what your opinion is, and how other units from the outside sometimes appear to work in comparison to ours?
So, I mean, that's something that I really value about our unit, is that we do have, it's, if you like, a very level playing field. We all are more focused on patient care and on enjoying our work, and don't put ourselves on pedestals. We have, as a result of that, a very good team structure. Everyone's very approachable, happy to talk to each other, and that makes delivery of care efficient, but it gives us great enjoyment in our work. Some units vary. Other units can be very friendly, effective. Some units are more dysfunctional, polarized, and people have their separate agendas and wish to grow their own individual departments rather than acting in a more holistic manner. I think that's just human nature. We're just lucky with the environment we've managed to foster and nurture.
That's excellent. So what I'm going to do, Steve, is just, because I do know you're busy, I'm just going to offer out to the floor for a few questions. I'll start with Saad.
Hi Steve, just wanted you to throw some light on our recent experience with the clinical fellowship. We just embarked upon something from our, for Zia actually coming to your unit and spending a year. How was that experience for Kingsmill?
So we were very pleased to welcome Zia into our unit, and it's been fantastically rewarding for us, as I'm sure that he's developed a great deal out of it. But he is a lovely guy, and he quickly built a good bond with the nursing staff in our unit, and became very quickly an indispensable part of our team. And I think that was it was very interesting to watch the how the dynamics changed. He came along to clinics with some of us as well, which was very useful, and I think also educational for him, because we just have a very different burden of disease in terms of the large volume of inflammatory bowel disease, which is less common in Karachi. And in terms of perhaps a slightly different way of culturally of interacting with patients, and obviously our unique NHS style of patient care and management. But in terms of his the growth in the endoscopy unit and ability to take things on, and the positive relation he built with the staff there and the wider team, it was really rewarding to watch, and we already really miss him.
The reason why I asked you, Steve, was obviously because that's something that we were. Zia has had a good time. He's obviously learned a lot, and it's given him a good, peep into what's happening in the developed world. And we certainly feel that's been helpful for him, and we obviously would want to continue that kind of thing. And that's why I asked you, because I've got juniors sitting here who obviously, some of them at least, if not all, would want to follow Zia's path and get at least some experience there, especially after what he tells us he's learned and the experience he's had. So on behalf of everybody here, I would like to thank you for having him, and we look forward to our continuous,
Well, we were delighted to have him, and we would be delighted to host other candidates in the future.
Thanks.
And if there's anyone who's interested in coming, then there's something that we'd be delighted to set up. So do let me know.
After listening to his experience, I was double-minded. I thought I would come and do a clinical fellowship there for a year too.
We would be very honoured.
I'd like to say that Zia has been a revelation. He's absolutely a superb doctor. He's a very lovely man. He settled in very, very quickly. He worked very, very hard, and he accomplished an awful lot. And he's come back working within the UK system. I'll show you later on a list of the accomplishments that he's done in a very short period of time. And the hard work is down to him. And Steve and a few of us just supported him along the way. So, has anybody else got any questions, please?
I was just asked, what difference did I see in Zia? He was quite a person when he left. He's come back. He appears to be more confident. Obviously, he hasn't started working with us because he's got 2 more years of his fellowship to complete. So he's going to come back next week. And when I spoke to him in UK as well as when he was here visiting, I felt his confidence level was much higher than what it was before. Before he actually left for Kingsmill. So that speaks a lot for what you guys have done to him. And all credit to you all for supporting him and giving him the opportunity and helping him throughout. Thanks.
Very well, thank you very much for inviting me to talk to you this morning, and wish you all the best.
You look after yourself, Steve. Thank you very much, my friend.
Bye.
Bye.
One of the things that was highlighted there is patient-centric.
I'll look at it. Can I access my email?
How the patient's experience, how is the patient going to be treated, what kind of experience they're going to have. And that's where we need to mention it. We can't do it in a system, but at least in our individual system, wherever we are, we need to bring patient as the main center of everything that we do. And their experience from the time they come in to the time they leave, it should be a pleasant one, a safe one, and an effective one.
What we're doing now is just loading a presentation from Lorraine. I've asked her to resend it me because I can't find it on my system.
We break off the lunch after these 2 sessions. Then we get back after lunch. And then we've got some problems, cleaning the scope, jack, and reporting. Colonoscopy reporting, and then we'll have a little feedback and all that. Wow, Paul, you could do that.
Only just. I ain't got a clue, man, what I'm doing here. I've got him telling me what to do. He's saying, do this, Paul, do that, Paul.
I always find this very difficult. recheck. And usually get another opportunity.
It's PowerPoint.
I didn't realize, but he told me, we worked as an institute.
He spoke nothing but high of you, my friend. Steve.
Oh, that's because that's like you. You know me, that's why.
Yeah,
That's like Wakar. He's not going to say anything bad about me. This is my friend.
that's the one. Right, the next speaker is Lorraine Clark. Lorraine Clark is a very interesting person. Very outspoken. She's a lady who is a very forthright and focused individual. She has the most yappiest dog you've ever heard in your life. And sometimes I keep talking about eating the thing. It's a very small dog. That's a very small thing. You'd like it.
I like to hear her remarks.
Yeah, she's funny.
Yeah, no, just say that to her. Feel like eating your dog. You want to hear what she says?
Yeah. So you may think that some things I may say to her is different. Don't worry.
Hello.
Hello, darling. Have you got your camera on? Or are you trying to
Can you
hide
see
your
me?
face? No, I can't see you. So,
You can.
Camera's off.
No.
are you in your pyjamas?
Can you see me now?
You're going to keep saying this to me all the time. Oh, yes. You've had
Yeah,
your hair
I'm not in
done.
my pyjamas.
You've had your hair done. Where's your dog?
Pardon?
Where's the dog?
The dog's not here,
I kept saying
and
to
I'm
people.
actually dressed today.
Lovely. Right, Lorraine, I was just chatting to people and letting them know a little bit about yourself, and I was just hoping that you'd be able to tell them as a, what we class as a senior endoscopist, IBD specialist, and all roughly what you do as a role, and then we'll lead into how you lead on the bowel cancer screening service into Nottingham in the presentation. Is that okay?
Okay.
Yeah, away you go.
All right then. So Paul, I've done this talk a few times, so do forgive me if you've heard it before. And Paul's asked me to talk about the situation around colorectal screening in the UK. The first slide shows some numbers of new cancer in the UK, and bowel cancer is the fourth most commonest cancer in our country. The incidence of bowel cancer is more prevalent amongst men, and it's thought to be about 75 in every 100,000 of our population. It's more prevalent as well in the north of the country, in Scotland, Northern Ireland and Northern England, where there's less affluent and due to lifestyle choices.
Presentation, isn't it?
Our number one cause of cancers are breast, followed by lung and prostate. Next slide, Paul.
No problem.
So cancer mortality, okay, so although it's the fourth most common cancer in the UK, in terms of mortality, it's second. It accounts for about 10% of cancer deaths in the UK, and again, obviously because there's more males affected than females, with lung being our top cancer mortality due to our smoking, which I assume in the next few years will actually change, because our smoking habit has actually changed as well in the UK. Next slide, Paul.
So I've got cancer
Okay, this
mortality in the
next
UK
slide shows-
2011. Is that the one you want? Cancer mortality UK 2011?
No, I'm on
Bowel cancer
the
screening, 2 cameras, two graphs.
2 graphs.
Yeah, that's fine.
Okay. This graph shows how the incidence of cancer, how it's risen since the 70s to today in the UK. And I'm not quite sure whether, well, we've got an ageing population, so that's one reason for this. But I think we're actually getting better at endoscopy and colonoscopy as well. And when we talk about some of the studies later, if you look at the bottom graph, that talks about a mortality rate. So although our rates are increasing, we don't know whether it's our detection that's actually better and our ageing population, but our actual mortality rate is going down greatly. And when I talk about the studies later in the presentation, it will show you that from about the studies in the late 70s and early 80s, there's only about a 50% colonoscopy completion rate. So there must have been missing an awful lot of cancers. So maybe that's because we're getting better at colonoscopy and we now have our screening programme in place. Now, our screening programme is aimed at the moment at the over 60s, and it's thought that about 19% of our cancer deaths is between 60 and 69. So they're included in the national screening programme. So the next slide, that just shows you, demonstrates a little bit about our survival rate in the UK. And we all know that if you're diagnosed with a Dukes A or B, that your cancer survival will be a lot better. And from the figures that you can actually see, our diagnosis before the bowel screening programme, so these are figures from before this programme was introduced, were quite poor in terms of diagnosing stage A and B. It was only a third of all of our bowel cancers. So the chance of survival was reduced quite greatly. And 2/3 were diagnosed at stage C and D. So the next slide. So why did we decide on doing a national cancer screening programme for bowel cancer? The thing is, most cancers arrive from polyps, and that gives us a window to be able to detect these polyps before they become a cancer. And it's thought that approximately 45% of those participating in the screening programme have pre-existing polyps, and 8% will have a cancer. So if we can pick these up in the early stages of A and B, then hopefully our survival rate will get better. Next slide, Paul. So this is evidence for using fecal occult blood, and this is one of the studies that I was talking about. There was 4 quite large studies that looked at the use of fecal occult blood, and one was done in our own hospitals in Nottingham, where we work. And this is one of the studies that identified how bad our colonoscopy actually was. Although that wasn't part of the study, when you look at this, when you analyse the study, this is what comes out of it. However, it's quite a large study. They recruited over 150,000 adults and randomised them into 2 groups. The interventional group that was sent fecal occult blood, they detected nearly 900 cancers and prevented, and there was 360 deaths. And in the control group that weren't sent fecal occult blood, they found less cancers and there was greater death. The other thing with this study was they looked at uptake as well, because it's not always acceptable to the population to be putting bits of stool on bits of cards. Some people just really don't want to be doing that. But they had about a 60% uptake, and of those that actually did the test and were found to have positive fecal occult bloods, 26% cancers were detected, which is a good thing. The thing that I would say though, there was about 28% of the population who had negative fecal occult bloods presented with a cancer afterwards. So the question is fecal occult blood a really good test to do? In my opinion, I don't think it's the best test, but it provides us with a gateway to our screening programme. It's thought that fecal occult blood though has reduced mortality in the UK in the 45 to 74-year-old population by about 16%. The next slide, Paul. So that study was done in the late 70s and 80s, and then in 2000 in the UK there was quite a large multi-centre study that looked at acceptability. We're still having problems with our ethnic minorities and our more male population in doing fecal occult blood testing, but there's quite a lot of advertising campaigns trying to raise awareness about bowel cancer. But with about 60% of our population that are sent the fecal occult blood tests actually return them. 82% that have a positive fecal occult blood go on to have a colonoscopy, and the rate of detection is about 1.62%, 1.26 of 1,000 population screened. And we are getting better at detecting Dukes A and Dukes B cancers. From this pilot, there was a number of aims that was directed for the colorectal cancer screening programme, and that is that the targets have been set at least 2 patients per 1,000 people screened by FOB will have a cancer, and at least 11 of the 100 screened, at least 11 per 100 screened colonoscopies. Does that make sense?
It does. Just to add to that, Lorraine, the last 2 bowel cancer screening lists I did, and that was 8 patients on the list, 5 had sigmoid cancers.
Right, the next slide just shows you how we deliver the programme. The programme's been going about 10 years now, and we have 5 central hubs. The National Screening Centre is actually in Sheffield, just north of Nottingham where we are, and initially it was delivered to 65 to 75-year-olds, and that's now been extended to 60-year-olds. Because if you think about the initial figures that I gave, the majority of people dying from cancer are between 60 and 69. The kits are sent out to all 60 to 74-year-olds every 2 years. 98 out of 100 come back as normal. Those patients then are put back on the register and sent another fecal occult blood 2 years later. There are a number of equivocals, so they would retest, and if they're still equivocal, they would come to colonoscopy. And about 2 in every 100 end up coming for colonoscopy. We've sent out, probably getting on for 21 million kits now, if not more, and the uptake is good. One of the problems with the fecal occult blood tests, and that's why we're thinking of changing in the UK, and I'll talk about that a bit later on, is the efficacy of the test, which I've already mentioned, false positive tests, and that can be affected by all sorts of things, such as your diet and what you eat, which includes red meat, orange juice, broccoli, and even dentistry. If you've had a bleed from dentistry, it could give you a false positive blood, fecal occult blood. So next slide, Paul.
Yep.
The next slide just shows you the process of delivery. So once they've had a positive fecal occult blood test, they'll be seen by one of our specialist nurses who will actually counsel them through why they've had a positive test. They'll tell them all about the bowel prep, and they'll tell them all about the test. Now this is one of the things that's up for debate in the UK, because we have walk-in well patients that enter a screening programme that get high-end care. They're seen before their test, they get counselled through their bowel prep, and they know all about the test before they arrive. On the flip side of that, our symptomatic patients that are arriving for colonoscopy, and in Nottingham in particular, they're sending a lot of patients that are referred by GP straight to test for colonoscopy. Now these patients are sent information at home to read about their bowel prep, so they have to decipher that themselves. They very often turn up very anxious because they've not had any counselling or any input regards their colonoscopy, and their consent is done immediately before the test. So maybe a few years down the line things may change, I don't know, but we do know that our bowel prep is significantly better in our bowel cancer screening patients, so our detection rate for small polyps is obviously going to be much better, apart from the patient's level of anxiety and the ease of doing the test. They will then be sent for colonoscopy. If something's found, they'll obviously go down the cancer pathway, or for polyps, they'll go into the surveillance pathway. But if everything's negative, they then get referred back onto the register for a fecal occult blood in 2 years. Next slide, Paul. Actually, you can. Right, so this is how we're doing. It's not the best of slides. So in Nottingham, so I'll talk about Nottingham. The aim is that each region in the UK has about a 60% uptake, and we're doing pretty well locally. Our adenoma detection rate has to be, their target is around 43%, and again, nationally and locally we're achieving that. And we're also achieving the target for our high-risk polyps and our cancers. So the next slide is similar to a slide I've already showed you, but what this slide demonstrates is how much better we're doing in terms of detecting polyps and cancers, well, cancers in particular, since the bowel cancer screening programme. And if you look at the first line, patients that are still presenting symptomatic, that haven't come through the bowel screening programme, still have that shortcoming of being diagnosed early. Whereas those in the bowel cancer screening line, you can see that it's actually flipped the other way. 2/3 now are detected at a very early stage, and we're actually resecting many more polyps at colonoscopy that are cancerous without having to do bowel resection. Next slide. The next slide's about quality assurance. And not everybody can be a bowel cancer screener, not every colonoscopist can be a bowel cancer screener. They have to go through rigorous training, which I'll explain on the next slide. But in terms of quality assurance and measured, this service is measured to the nth degree. They have training, and they have to go through everybody who does bowel cancer screening has to go through a colonoscopy driving test, where your colonoscopy skills are scrutinised by 2 external assessors, expert colonoscopists. You have to pass an MCQ paper, and you're mentored through that as well. And now we've seen the emergence of pre-assessment training courses around the country as well, which are very good and expert-led. There's recommendations by the National Screening Board that you have to have specific equipment in the room, and without that you can't do your bowel cancer screening lists. Each centre has to be JAG accredited, which I'll explain on the next slide. Each colonoscopy has real-time data collected. There's a nurse specialist present, and she collects everything in terms of how long it takes you to get to cecum, how long your withdrawal is, how many adenomas you detect, how many you pick up, and all your cecal landmarks to make sure that you're doing what you should be doing. All this data is published nationally, regionally and locally, so there's transparency, and if there's any discrepancies in what we're trying to achieve, then this is dealt with. Next slide. It's still about quality assurance. I just mentioned JAG accreditation. So before you can have a bowel cancer screening programme in your hospital, again, your unit is scrutinised to some degree, to the nth degree in fact. They look at everything in terms of your education programme, your training, your decontamination, your patient information, your guidelines, and they come and look at every piece of documentation that you've had and your patient feedback as well. And it's only then that you can run these bowel cancer screening programmes in your trust. And this is another area that's causing a bit of controversy at the moment, because some units are failing their JAG accreditation, and the smaller units are under threat of not being able to function even to provide their normal endoscopy service. So that's another thing that's up in the air at the moment in the UK. Every centre must have a screening lead, and you must do at least 150 colonoscopies a year and have a lifetime experience of 1,000 colonoscopies. And there's a few other criteria in there as well. The next slide, and I'm sure Paul, if you talk to Paul, he's got this somewhere, if he's not already shown it you. This
I'll be showing that shortly now, Lorraine.
JAG website for recording all your colonoscopy, endoscopy, ERCP, whatever you're doing as a trainee. And you can carry on doing that once you've been signed off. And nobody is now allowed to perform colonoscopy, gastroscopy or ERCP in our country unless they've gone through this process of being signed off. And there's quite a lot of criteria in there that you have to achieve before you are summatively assessed by two assessors that have not been your trainee before you can perform endoscopy. Have you shown this to everybody, Paul?
I'm going to be showing it shortly, Lorraine, along with a lot of the other accreditation stuff.
So I'll leave that with Paul to explain to you. The next slide is what is the feedback that each colonoscopist gets. It's their key performance indicators from the bowel cancer screening team, and these are all the measures. I've already mentioned that you have to do 150 colonoscopies. You have to achieve above 90%. That's the target doing a bowel cancer screening, but that's risen. I think it's 95% that they're now, or is it 97%?
It's 95
So,
and they're expecting 97.
Yeah, it's expected 97. Now, failed colonoscopy, we don't really have anything that is taken out. So if you've got an obstructing cancer or you can't see because of bowel prep, that goes down as a fail. So there's lots of things that go down as a fail that it'd be impossible to actually reach the cecum safely anyway. Intubation rate, I've mentioned. Withdrawal time. Now, the other thing that I find difficult is when we book our normal colonoscopy patients that are presented with symptoms, they're given a 30-minute slot. For our bowel cancer screening patients, they're given a 45-minute slot. So you've got much more time to perform your procedure. Obviously, if your withdrawal time is much slower or your intubation time is much slower, your chance of finding smaller lesions is going to be much greater. And I think this is something that needs reviewing as well nationally as to what we do for all of our patients. Complications, the complication rate in your normal service list, a complication is probably seen as a big bleed or a perforation. All the bowel cancer screening patients are telephoned the following day by a screening practitioner who their complications include anything from a little bit of abdominal pain to a perforation and death. I saw a presentation last week looking at figures from that have recently been published at local level, and there was a patient that had a perforation in the bowel cancer screening team, and it was clipped, it was sorted. The patient didn't even go into hospital, but this was counted as a severe complication. Do you want to add to that in terms of complications, Paul? What they
Complications
publish?
themselves, they do monitor everything. I think the fact is that sometimes we invite a complication by a little bit of abdominal pain, and some of the specialist nurses will invite the patient to come to casualty rather than locally managing the discomfort by understanding what can actually be causing it. So as soon as the patient turns up to casualty, it goes from being a low level complication to being an intermediate, which then forms alarm bells. So I think sometimes we need to educate people a little bit more who are actually doing the phone calls. And that's come about over the last 2 years, and we're finding less people being classed as intermediates. complication rates within Nottingham are very low, and we actually take off, if you actually look at how we look in the league table, and there are league tables, we take off the third most polyps, and we are taking off percentage-wise more level 3 and level 4 polyps than any other centre, and our complication rates are the lowest of all centres in the UK.
Okay, so what we've moved on to now, the next slide, Paul, is bowel scope. So we're now looking at offering, well, we know that our bowel cancers occur between 60, our mortality is 60 to 69. So 60 is a bit late, but to start your colonoscopy screening. So now they've introduced bowel scope screening for all 55-year-olds. This doesn't include, they don't have to have a fecal occult blood, they just sent an appointment to pitch up for a flexible sigmoidoscopy to look at the left side of the bowel. And the thoughts behind this was based on a multi-centre random control study which recruited 170,000 patients over 11 years, and they looked at 55 to 64-year-olds, and about 60% of cancers were found in the distal part of the colon, and that's the rationale behind offering flexible sigmoidoscopy. Now we know that the gold standard is colonoscopy regardless, but we don't have the facilities or the resource to give everybody a colonoscopy at 55. But the question, what about those patients that will present with a right-sided cancer? Of the group that attended for the FlexiSig in the screening side of the programme, the control group, they had one life saved per 200 screened. So that's quite a significant number. Over 40,000 came for flexible sigmoidoscopy, and of 48 patients per centre per week, 2 or 3 went on to have a full colonoscopy because polyps were found. And 62% of cancers found, so polyp cancers, were excised locally at flexible sigmoidoscopy.
I think there's two important things to actually state though, Lorraine. Bowel scope is about early detection of polyps, and bowel cancer screening, the reason why it came about is early detection of cancers. The other thing that I think Lorraine has also alluded to, which may not be obvious, is that yes, there are other bowel cancer screening programs throughout the world, but in the UK they look to accredit the colonoscopists, and what we're finding is that the risk from the procedure, if you actually look at worldwide doing a screening colonoscopy, patients who are asymptomatic, got no symptoms, who have a colonoscopy, have been suffering severe harm, if not death, of a higher risk rate than what they would do if they developed cancer. So if you look at the two groups and didn't bother screening, the chance of dying from an undetected bowel cancer is lower than having the colonoscopy. So the UK tackled it by doing an accreditation process, and so that's why the UK has all this accreditation and assessments. Onto fecal immunochemical tests, Loz. Yep.
So what we've been looking at is fecal immune chemical tests, FIT. I'm told that they're going to start trialling this in the UK. There's been lots of talk about the cost of it and how much cost, but it is more, the efficacy is better than fecal occult blood, which may reduce the numbers of patients coming for colonoscopy, or may increase it because we may get less false positives, false negatives. I don't know the answers to this question as yet. I don't know if you know any more than I do, Paul, but it is in the very early stages.
I know that it's more target specific, Lorraine. I think it will actually cut down
healthcare system in the UK.
Yeah, I think it'll cut down on the demand in 1 or 2 cases, be more target specific. I think the fact that we're going to be, it's a less sensitive test, so we're hoping I think we'll detect possibly more cancers in the group that we actually scope, but I think the demand for colonoscopy will widen and we'll be able to look at the age group accordingly.
So the last test just summarises that our cancer screening programme has detected more cancers and is detecting more cancers at an early stage, and now mortality has reduced greatly. It needs to be more acceptable to a greater population, so we've got quite a lot of work to do with the media to recruit more patients into the bowel cancer screening programme. One of the things is with the bowel cancer screening programme that we have to consider, it's the only health screening programme where the risks are high that you could die from it. That's what I'm told, and that's why it is so stringently policed, so to speak. Fecal occult blood isn't without its faults, as we've discussed, but it's where do we go to next? And we all know that full colonoscopy is the gold standard. Thank you very much.
Thanks, Loz. Just 1 second. I just want to make sure that we get your picture into the... I don't want to... Do we double click it? Now you're full focus. How are you doing? Now, I'm going to ask you, is there any questions at all from anybody? Yeah, we've got a question.
Okay. Hello, Lorraine.
Hello.
Dr. Munira. Yeah.
Hi.
Lorraine, I have a question. As we said, in UK, we have a bowel cancer screening program running very successfully, but still we are subjecting lots of individuals to unnecessary scope for the screening purpose. And way back, we know the benefits are more comparing to the outcome of adverse. But what do you think will be the cutoff age of screening at UK to screen the bowel in high risk and a non-high risk group? Number one. And another question is that, despite of subjecting the individuals to unnecessary scopes in the near future, do we have a non-invasive testing like stool DNA to detect malignant cells that can replace this invasive unnecessary scopes to the individuals in the near future?
I didn't quite get all of that.
So,
Could you
Lorraine,
just,
really, to be a little bit looking at the question, one, is there a non-invasive test in development that you know for that's DNA specific? And two, what is the upper age limit for bowel cancer screening? So if the person comes for, what is the upper age limit?
Okay, so if I answer the last question first, the last question, so the upper age limit at the moment is 75. Now, patients can actually request to still have fecal occult blood tests. They have to go to the GP and request that, so they can continue within that programme. So, but at the moment, the upper age limit is 75. And your first question was about unnecessary colonoscopy.
Yeah, is there a other test that's non-invasive that will actually be DNA specific, for example, in the pipeline? So I know you said on your last slide in summary, gold standard is colonoscopy.
Yeah, we do use CT colonography for patients, but these are patients that are not fit for colonoscopy. And we do have some problems with our radiology department, particularly in Nottingham, because obviously they're inundated with the procedures that they have to do as well. So CTC, but again, CTC is not foolproof, is it?
Not foolproof. Just to
No.
add, Lorraine, I think that what there are several studies out there that are actually looking into DNA targeting, secreting.
DNA targeting, right.
So there are ones. The
Yeah.
other one is that we are seeing radiological imaging where they can actually take a sample of blood, re-inject, and they can radiologically map the colon. And if the colon looks slightly deformed, then they know there is a polyp. So that's a less invasive way, but it does expose a person to some low radiation imaging. So there are various things and tools that are in the offing. The problem comes is the sensitivity and specificity. So sensitive to the test, specific for the to detect cancer. So that's where we haven't got enough information yet to know, is it sensitive enough? Is it specific? So once we understand a little bit more about that, then we can actually then say, yes, this can replace or be a substitute for. But currently, to visualize a colon, a live colon, is seen as being the gold standard, and I can't see that changing for the next 5 to 10 years, to be quite honest.
I'm sure in the next 5 years, you know, presenting this as it is now will be a completely different picture in 5 years' time, and in terms of our normal service colonoscopy. I think that it's time for change.
Another question, Lorraine?
Yeah.
Like that 75 is a cutoff for screening bowel cancer in a normal individual, with no family history or high risk group. For the high risk group who are meeting the criteria of Amsterdam criteria or Bethesda criteria, having a colorectal cancer as a family, then what would be the cutoff for their family?
Okay. So Lorraine, we're
I'm only
talking
catching
two different
bits of the
groups
question,
here.
but I presume you're on about people that are high risk with family history.
Yeah.
These patients, again, they don't come into the bowel cancer screening. If they're under 60, they don't come onto the bowel cancer screening program. They come into a normal service list. So again, you could actually question, should this group be in the bowel cancer screening program? And that is something. That is a very good question. It's something for consideration that we need to think about and actually take back to our program board.
Lorraine is actually the lead for bowel cancer screening in Nottinghamshire. Even Lorraine has got some doubts, and I'm not speaking for her, about the how it's delivered. We actually deliver for asymptomatic patients who have done a fecal occult test that's positive, and we actually scope those, and we invest a lot more time, a lot more effort into that group. The group you're identifying, which the Amsterdam criteria, they come under our normal populous day-to-day work. So those patients are put through a normal route, a normal pathway. So a bowel cancer screening patient, as a colonoscopist, we spend 45 minutes with. An Amsterdam criteria patient, we will only spend 30 minutes with. The issues also come is that we asked genetics to look at how often we need to be looking and scoping patients, because, as Steve alluded to earlier, the demand for colonoscopy is going up and up and up. So we have to look at a way of making sure that when we do a test, it's the most optimum time to actually deliver that test. And so there are times when in the past, under genetics, we'd scope someone every 2 years. Now we're looking at scoping people every 5 years, and we've asked them to look at it quite significantly. There is not data out there yet to actually say that. But anybody who is asymptomatic, FOBT positive, they go under this process, and all the data you've seen is parted to this process. Anybody else, Amsterdam, rectal bleeding, they come under our normal process, seen in clinic, direct referral, and they get sent out an invite, etc. So
I do think, Paul, that's something that we do need to take back to the screening programme.
The only concrete data
I can hardly
we've
hear
got
what you're saying. I'm picking bits up.
Oh, sorry. Lorraine, the only concrete bit of data we've got in the UK to actually talk about standards, effectivity of our colonoscopy technique, how things have developed, detection of polyps, detection of cancers, all that data really comes from, and is robust, is clinically robust, is from bowel cancer screening data. And this is an asymptomatic group. What we haven't got is the same data for patients who are the symptomatic group. We haven't got the systems, even in the UK, to do that. Any other questions? Well, Lorraine, thank you very much for your time.
Yeah, it looks like it's coffee time anyway.
Oh yeah, well they brought in and everything. Actually, lunchtime here, Lorraine.
Oh, lunchtime.
Nice
Lunchtime.
kitchen. And nice that you she actually bought a new computer to do this presentation, because her last computer was rubbish.
Okay. I have. I had to go and buy it last week, but I'll make it better next time.
Hey, no,
All
Lorraine.
right.
Absolutely super. Take your time, Lorraine. Look after yourself. Thanks for your time. Was that useful for people? close down my email so Sharia can't see who I'm talking to. Sign out? Did I sign out, man? I just exited. He's hid it. He has some data, you know. I'll bring it up shortly for you when we do. There is a talk on that, and we'll do that presentation. The other thing is we will give out our contact details later on as well, so you can contact us. If there's anybody that you'd like to have further discussions with, Lorraine is more than happy to chat to you as well via email, etc. So she's very happy to do that. Stevie is busy, but he will answer emails after a month, so don't worry about it. But myself, you're lucky if you hear from me within a week. So, but Lorraine is also about a week when she gets back to you. But we do answer you any questions you've got. That's not me doing all that. That's him.